Hi there, my name is Dr. Ankit Shah. I'm a radiologist practicing in Mumbai. On this channel, we will be discussing all things related to musculoskeletal imaging, the focus being musculoskeletal ultrasound. So, starting with this case, we had a 42-year-old male with a painless knee swelling following a motorbike accident which had occurred 3 days ago. Here we notice a prepatellar swelling extending to the superior medial aspect of the knee joint. We do see some healing abrasions over the anterior and lateral aspects of the knee as well. When we look at the lateral radiograph, we see a large soft tissue density at the expected location of the prepatellar bursa. Hence, a provisional diagnosis was hemorrhagic prepatellar bursitis. Ultrasound images obtained at the level of patella and along the superior medial aspect of the knee joint show a complex collection which is interposed between the subcutaneous fat and the deep fascia. You will notice incomplete septae and entrapped fat globules. So when I apply pressure over here, what we see is there's displacement of the fluid as well as movement of the fat globules. Application of pressure shows displacement of the fluid, confirming the cystic nature of the lesion, and identification of the fat globules is important since that will help us in narrowing down our differential diagnosis. The extended field of view images or the panoramic images show us the big picture, showing the exact extent of the lesion in the axial plane. So over here we see that the collection is seen elevating the subcutaneous fat from the deep fascia. I have marked the deep fascia as a blue dashed line. So what we see is that the complex collection is seen in a potential space which is formed between the deep fascia and the subcutaneous fat. When we look at power Doppler images, we see that there is some hyperemia at the level of the uh, deep fascia that we see over here. Okay, so apart from that, there's no vascularity within the collection. So the three main differential diagnoses would be a Morell Lavallée lesion, hemorrhagic prepatellar bursitis, and traumatic fat necrosis. Especially when I see an image like this at the level of the prepatellar bursa, my first diagnosis would be hemorrhagic prepatellar bursitis. However, once we have a look at the entrapped fat globules and the typical history of a shearing force, my diagnosis would be a Morell Lavallée lesion. Now, Morell Lavallée lesions are typically closed soft tissue internal degloving injuries. Okay, so what we see over here is this is a subcutaneous fat, the deeper layer is a muscle, and between both of them is a deep fascia. Over here we see the deep fascia as a gray bar. Now between the deep fascia and the subcutaneous fat you have capillaries as well as the lymphatics running across the tissue planes. So whenever there's an external shearing force which is applied, the subcutaneous fat moves ahead and there's disruption of the capillaries and the lymphatics, resulting in formation of a venolymphatic or a hemorrhagic uh, and a lymphatic collection which forms between the subcutaneous fat and the deep fascia. The key to identify a Morell Lavallée lesion is that you scan at the periphery of the lesion and you see that the subcutaneous fat and the deep fascia are almost are approaching are approximating with each other, and there's a cleavage plane which is formed between them. So this is the key. Now Morell Lavallée lesions, they are formed in four stages. So there's a stage 1 when there's a separation of the dermis from the underlying fascia. There's a stage 2 wherein there's collection of blood, lymph and fatty debris. Stage 3 is replacement of the collection with serosanguinous fluid, and stage 4 is pseudocapsule formation. Most of the time, as radiologists, we image the Morell Lavallée lesion in either stage 2, 3 or 4. All right. Stage 4 is a much more chronic stage wherein the patient might just come with a deformity or pain at the site of the Morell Lavallée lesion. The Morell Lavallée lesion is a chronic source of pain, and some of the patients might just come with disfigurement saying that I have this lump developing over here. The most common locations of Morell Lavallée lesions are the greater trochanteric and the hip region, followed by thigh, pelvis, and knee. And of course, there are other areas like the gluteal region, the lumbosacral area, and so on. But the most common areas are the greater trochanteric and hip region and the thigh. So what we see over here is there's a Morell Lavallée lesion in the gluteal region. The T2 images over here show a hyperintense collection which is bordered by a thick capsule which has been marked by arrows. Ultrasound appearance of Morell Lavallée lesions can be quite variable depending on what stage you image the patient and what is the predominant component of the fluid. So in the early stage when you image the patient, the only thing that you might see is a little bit of edema in the subcutaneous fat. Then as the collection gets more organized, you might see a proper collection forming, and in the late stages what you see is a fibrous capsule formation of variable thickness, but this is how the capsule would look like. The collection might look anechoic, isoechoic, it might look like a complex collection with or without septae or low level echoes depending on the stage or the quantity of blood within the collection. The treatment of Morell Lavallée lesions depends on uh, the volume of collection and the site of collection. Okay, most of the smaller lesions are managed by closed observation. You might want to aspirate the lesion if the volume is typically less than 50 ml, but you have to know that the recurrence rate of simple aspiration is quite high. So it's almost as high as 56%. Large lesions might actually require formal surgical debridement, and if the lesion is following aspiration, if the Morell Lavallée lesion recurs, then it's worthwhile considering to inject a sclerosing agent like doxycycline and so on. Now coming back to our patient, what we did is we did uh, an ultrasound guided aspiration of the fluid from the non-dependent area of the knee. So what we did is we used a 18 gauge needle and we aspirated the fluid since the patient had come to us for the first time. And what we got is a fluid which looked like this. We aspirated 140 ml of hemorrhagic serosanguinous fluid. Followed by that, we applied tight bandages, compressive bandages over the knee so that we reduce the dead space. That's all from me. Thank you so much for watching. Let me know in the comment section below if you have any suggestions or you would like me to cover something in particular in the subsequent videos.